My name is Zavanya Covington, and I am the Community Partnership Coordinator for Faith-Based Partnerships and Senior Strategies in the Social Responsibility Department here at Baptist Health. So our topic this month is diabetes, and we have a special guest speaker tonight who I will be introducing in just a moment. But first, I would like to review tonight's agenda. So I will review a couple of housekeeping items. We'll have the presentation and the Q&A by our special guest, and we will finally end with some brief closing announcements. So there are just 3 housekeeping announcements that I would like to review tonight. And I would like to do that before we get started with the presentation. So first, we are recording tonight's session, and it will be made available to all of the registrants. Secondly, we are tracking tonight's attendance. So if you have invited others to view with you who did not get an opportunity to register, we first say thank you so much for spreading the word for tonight's session. And we just ask that you add those persons' names to the chat so that we can document the attendance for our records. And thirdly, my director, Lynn Sherman, she will be monitoring the chat during the presentation. So please feel free to type your questions there, and during the Q&A segment, they will be addressed at that time. So without further ado, I would like to introduce our speaker for the evening. Dr. Trishella Johnson Foy is an experienced board-certified family physician with more than a decade of experience who focuses on compassionate, patient-centered care. Dr. Foy completed her residency at forgot to show her picture, I'm sorry. Dr. Foy completed her residency at the Mayo Clinic, Jacksonville, and is trained in diabetes, and she is a master clinician with expertise in most chronic conditions. Dr. Foy chose to be a family physician out of a desire to provide continual life care to patients and their families. She believes that focusing on wellness and prevention is essential to truly caring for our community. So Dr. Foy, thank you so much for being here with us tonight. So if you want to go ahead and start sharing your screen, I'm going to stop sharing mine. And you can begin when you're ready. I think you're still on mute, Dr. Foy.
There we go.
Okay, there we go.
All right. Well, thank you so much for the introduction and for allowing me an opportunity to speak with you guys tonight. It's always truly a pleasure, and diabetes in particular is something that I really enjoy trying to educate people on. And most often there's not enough time because there's so many things that there are to know. And although a lot of people have an idea of what diabetes is, we want to take a step back today and really help people understand how this disease is affecting our community, our country, and perhaps how do we move through this epidemic. So the idea today is to really talk about some truths and get into some things that you may not have been clear on about diabetes, like where the diagnosis comes from. When it comes to diabetes, we are truly dealing with an epidemic. I know for the last couple of years, the most important thing that's been on people's mind has been COVID, but there's an epidemic that has been ongoing and long lasting. And if we don't make some crucial changes to what we are doing with our health, then this epidemic will be with us for a long time and really have some dramatic and tiresome effects on our community. When it comes to diabetes, it's not just the United States that is affected by this epidemic. It's truly a global epidemic that is projected to increase and worsen as the years pass with the current trajectory that we're on. In the United States, it's thought that we'll have a 36% increase in diabetes from where we were in 2011 to where we will be in 2030. Now, 36% sounds like a lot, but if you look more globally, you'll see that countries, places like a continent like Africa, there's thought to be a 90% increase in those who will be affected by diabetes during this time frame. Now, and I apologize for some of the blurriness of the slides, but what you can definitely see is this upward trend in the number of people who have diabetes and are expected to have diabetes by the year 2050 in our country. This is a grand increase from those who are diagnosed in 1990. So it's affecting our entire country in a way that we must take steps now to do something about. So why has this trend been occurring? Well, not only has diabetes increased, obesity has been one of those things that we've seen increase considerably. Currently, about a third of adults in the US are obese. Now, obesity is related to many conditions, not just diabetes. So we have to worry about things like heart disease and strokes, sleep apnea, arthritis, and even some cancers. A lot of people don't know and don't realize that obesity is related to an increased risk of cancer. But the biggest concern is that this increase in obesity has been consistent with this increase in diabetes. So there's an 85% higher chance of people who are obese having diabetes. So as we move forward and we look at how things have transitioned over time, back in 1994, when we were looking at our population and the amount of obesity in our population, and by obesity, we mean when your body mass index, which is your height versus your weight, is over 30%. Now, some people will say, well, what about Black people? That number isn't the same. We're using this number in the general sense. And once it gets about 30, then it is about the same. It's something that can be reliable despite ethnic differences. What we know is in this country since 1994, our scale has changed from being less than 14% to more than 26% of people having obesity. It is consistent with those people who have, you can see the map as it continues on, that it is also showing the same trends in diabetes. And so obesity and diabetes go hand in hand. My slide went a little faster. There we go. Obesity and diabetes have really gone hand in hand, and there's really not many places in our country that has gone untouched by this. When you look at even the Hawaiian Islands and Samoa, and a lot of our country has been affected by this obesity epidemic and by diabetes. But before we get to diabetes, people's sugars start going up in a range that is unhealthy to their body. And this is that time frame of pre-diabetes. The same way we have seen this obesity epidemic increase and cause more diabetes, there's thought to be about 471 million people globally who will have pre-diabetes by 2035. Now, these numbers aren't in stone if we will do those things that will help decrease those trends, like proper lifestyle changes and interventions. So that's eating right, exercising, and some things that we'll get into more later. But when you put diabetes and pre-diabetes numbers together around our country, that means about half of our country will have one of these conditions. It's not only affecting our health, but it's also affecting our economy and our bottom line. When you look at the fact that about 86 million people have prediabetes and 30 million have diabetes, that means 1 in every 3 Medicare dollars spent is spent on treating diabetes. 1 in 5 healthcare costs in general is spent on people who have diabetes. That's about $322 billion a year. And there are some studies that say it actually is even more than that. So on this day, about 3,800 to 4,100 people will be diagnosed with diabetes. Because of that, 200 Americans will undergo amputation secondary to diabetes. 136 of them will enter end-stage kidney disease and need to be on dialysis and treatment. And about 1,800 will develop severe retinopathy that can lead to vision loss and blindness. So yes, it has an incredible effect on our overall health, which in turn has an incredible effect on what our economy has to spend on taking care of people. This again can all be changed if we focus on ending this epidemic and getting our health under control. So it's not all bad news, but we definitely still need to do something about it. This is the first time after almost 2 decades of increasing the rates of patients who have diabetes that we've saw a decrease or a decline in the number of people who are newly diagnosed. It decreased from about 9 in 1,000 to about 6 in 1,000. Those may not seem like dramatic differences, but when you look over the millions of people in our country, that actually is some improvement. And some of that has to do with the legislation that we've passed to decrease how our food is presented, the amount of fat that's allowed to be in it, the amount of sugars that are allowed to be in it, labeling of foods. A lot of these things are related to that. So yes, there's been a decrease in new diagnoses of diabetes. Unfortunately, though, there's still been an increase in the number of people who have pre-diabetes. Now, the reason why is because we're testing more. We've defined it better. We know how to really look at what it means to be in that pre-diabetic range and are educating people in talks like tonight on what numbers they should be looking for. Now, there are still certain groups that are going to be more likely to have pre-diabetes and diabetes. And that's when you're looking at your Native Americans and Alaskans, African Americans, and then non-Hispanic Asian people. They are more likely to have diabetes than non-Hispanic white people. So certain ethnic groups need to pay closer attention in their communities to finding ways to prevent and treat prediabetes and diabetes. So because we've been dealing with this COVID pandemic, though, what has happened during this time? Well, what we found with COVID was diabetes is one of the main risk factors for people developing severe illness. So it's not just that diabetes alone can have a tragic effect on your body if it is not treated properly. It can also make other conditions worse. So COVID-19 and patients who had diabetes, particularly uncontrolled diabetes, were more likely to have bad outcomes and were more likely to die from COVID. So it's just even greater reasons for us to make sure that we help to prevent this condition. So who's at risk? I told you that there are many ethnic groups that are more likely to develop prediabetes and diabetes, but the risk doesn't stop there. If you're over 45 years old and you're not very physically active, meaning you're not doing exercise at least 3 times a week, if you have a family history of diabetes, high blood pressure, or a history of gestational diabetes, which means you had diabetes or you had sugar problems while you were pregnant. And definitely if you're overweight. Now, some people think it's just obese, and that's that medical definition of obesity, which is over a 30% body mass index. But between 25% and 29%, that's the overweight category. And if you fall into this category, then you're actually at risk for prediabetes, which essentially can lead to some of these same problems. So if you have family members or friends who believe that they don't have to worry about diabetes and sugar issues because they're not obese, then you can educate them on the fact that even in the overweight category, you have issues. Then I have people whose body mass index isn't above even 25%, and they still have prediabetes or diabetes. Well, why is this? I told you family history is a big contributing factor to developing prediabetes and diabetes. And unfortunately, some people, that is the thing that matters the most. So prediabetes is actually your number one risk factor. Although some people will say, well, I don't have anybody in my family that I know who has diabetes, or I don't know anybody who's ever been diagnosed with prediabetes. One, somebody has to be the first, but also historically, we haven't always cared for ourselves in a way where we truly know what's going on with our bodies. And some people have had these numbers that have been high and just haven't known about it throughout the years. So tonight we're going to learn, well, what are the numbers? What should we be looking out for? Now, before we get into specific numbers, there are many times people say, hey, it's possible to just have a little diabetes or a touch of diabetes, and I'm really not having a lot to worry about because my sugar is just a little bit high. Well, what a lot of people don't understand is by the time we're saying prediabetes or diabetes, that means there's damage and effects that are being done to your body from your sugar being elevated. So even in the lower ranges of these elevations in sugar, you can start seeing damage to your organs and to those things that are important in your body. So I'm going to take a minute with this slide because I want you to really understand. So the blue line is retinopathy, which means eye damage, or think retina. So eye damage, as you can see, yes, it is something that when you are on the lower end of the scale, it is less likely to happen, but it can happen. The worse your sugar gets, it is going to be more likely that you develop these problems. So the number on the bottom line is what we call the hemoglobin A1c, and that's the 3-month blood sugar average. So this 3-month blood sugar average tells us all day, every day, what your sugars have been running. So at 6, this would be considered pretty controlled diabetes. That means you're doing really well taking care of your sugars. But you can see these changes and these problems actually start here. They are not 0 when they're at this level. Yes, they are less likely and better than when they are in that 12 range, which is when the sugar is terrible, but it's definitely still happening. 7 has been the number that the American Diabetes Association says is a reasonable number for most people to be considered to have decent control of their diabetes. Well, as you can see, the scale has already started to increase in eye damage. The red line is kidney damage or nephropathy. That's what that is standing for. And you can see, even when your sugar's good, you can get kidney damage. Neuropathy or nerve damage also can happen even in those early stages of increases in your sugar. And a lot of times people, that's the way they present. They'll come in and they'll say, Dr. Foy, I'm having this feeling, this creepy crawly sensation, or my feet are burning or numb or tingling, and we'll check their sugar and it'll turn out that they actually are presenting with prediabetes. Now, microalbuminuria, or this yellow line, is about very early kidney damage. And so this is the first signs that the sugar is affecting your kidneys. It is also related to what is going on in your heart. As a matter of fact, once we start seeing this increase in these tiny little proteins coming from your kidneys into your urine, then that is also related to the fact that there's likely some damage going on in your heart. So if your doctor is telling you, hey, you have these little proteins in your urine, don't worry about it. Know that, yes, it isn't something that suggests you're about to be on dialysis or have kidney needs for your kidneys to be really bad, but it can be a sign that we need to pay a little bit closer attention to your heart. So what really are these numbers that will tell us what is diabetes and what is prediabetes? Diabetes, first and foremost, means your body has lost the ability to keep your sugars under control. Your pancreas, which is an organ that sits right behind your stomach, usually produces insulin to keep your sugar levels in a normal range. Most people who have normal sugars, when they wake up, it should be around in the 80s range, but definitely less than 100. So 99 or lower is considered normal. If it is 100 when you wake up in the morning, then that is considered pre-diabetes. The numbers 100 to 125 are numbers that tell us your body really isn't controlling your sugar the way we want it to, and that we've got to start really paying attention to get it down. I will tell you that from my personal practice, if I have someone that I know has a strong family history of diabetes, if their fasting sugars are in the 90s, even before it gets to 100, I really start having strong conversations with them about the fact that they should start eating and living a lifestyle like someone who's already been diagnosed with diabetes, so they decrease the likelihood that they ever cross over into that pre-diabetic or diabetic range. Now, full-on diabetes is when your fasting blood sugar is 126 or greater on more than 2 occasions. So if you go in and your doctor says, oh, it's around 127, but we'll just keep watching it, then that for you is a sign that, hey, I might really have diabetes. So at that point, we check it again, or we go on to do some other tests to look for actual diabetes. So the numbers that you have and those number ranges that we get, if your sugars are staying in the normal range, then your hemoglobin A1c, which again is a 3-month reading that says all day, every day, what your sugars have been running for the last 3 months. So even if you have eaten a piece of cake while we have checked this level, it won't really affect it because it's based on the numbers what they have been in the past. The reason why it's 3 months is because your blood cells lives about 90 to 120 days inside your body. And so because of that, they pick up sugar as they're circulating around and around and around. And if the numbers are normal and staying less than 100, if I check a A1c or that 3-month level on you, then it'll be less than 5.7. If it's starting to creep up in those 90s, then you'll start seeing higher fives like 5.4, 5.6, 5.5. Those are when we're starting to see in the 90s. Now, when it's in the low 100s, that's when you cross over and you're in that pre-diabetic state, and it's in the 5.7 range. So the higher your sugar numbers get on average, the higher this 3-month blood sugar test will be. Now, when I was actually training to be a doctor, we didn't have a clear definition of this pre-diabetic state. I trained at the Mayo Clinic and I feel pretty good about my training. So what we were trained on was if that A1c was greater than 6, then that patient was considered to have diabetes. Now, since that time, a group of minds came together, people from the American Diabetes Association and American Endocrinology Society, which are the special doctors that take care of diabetes. They met and they agreed that 6.5 was going to be the cutoff for making an actual diagnosis of diabetes, and that we would use those numbers right in between to call prediabetes. The reason I'm taking the time to tell this story goes back to what I told you earlier. Even in that yellow range, damage is starting to be done inside your body. So you don't have to not worry about things until it becomes diabetes. You want to start really focusing in on treating yourself appropriately with those lifestyle changes before you get to that pre-diabetic state. We want to make sure that we never hit the yellows and the reds, and definitely don't want it to start being above 6.5, because that's when diabetes has truly stepped in. And this range just kind of puts it together. I don't know if you want to take a picture of it so you understand. The green, once again, less than 5.7, less than 100 fasting blood sugar, and an oral glucose tolerance test. So the oral glucose tolerance test is where we send you to the lab and we give you a little load of sugar. If you've been pregnant before, then you have had this done, but we give you this little load of sugar and then we measure what your sugar is in 1 hour and then again in 2 hours. If at 2 hours, it falls between, and this scale says 144, but really between 139 to 199, then we consider that pre-diabetes. If it's greater than 199, then that is considered diabetes. If it's 200 or higher, 2 hours after that glucose tolerance test, then that's considered diabetes. If your fasting sugar is greater than 126 on 2 occasions, that is considered diabetes. And if your hemoglobin A1c is greater than 6.5, then that is considered diabetes. Now, with prediabetes, you actually don't have to have that glucose tolerance test be in that higher range. Sometimes you pray up real good and you go in and take that test and those numbers fall within normal. But if your fasting sugar was elevated to greater than 100 but less than 125, then it's still considered prediabetes. And this just restates what I've told you. So the only thing, if you look at the bottom line on this, it says a random plasma glucose greater than 200. That means if we check your sugar at any time and you've been having symptoms of diabetes, like feeling extra thirsty, extra hungry, vision changes, numbness or tingling, and we check your sugar and it's over 200, that also is considered a diagnosis of diabetes. So again, I got ahead and it's restating all of those things that we talked about, criteria for diagnosing diabetes. And it's important to understand this because, again, a lot of people don't know and they think it's just from the hemoglobin A1c. And I've had many times where I've ordered a hemoglobin A1c and it's been 6.2, but then I do a glucose tolerance test and it's greater than 200, which tells me their body is probably just developing diabetes, but that it's definitely diabetes, and that we need to do the things that we do to take care of people who have diabetes. And so if your doctor says, well, your A1c is just a little high, I do think it's important for you to ask them if you're concerned about making sure it's not diabetes, is to order you a glucose tolerance test so that they can be certain that they don't need to start doing those other things like making sure that your eye exams are up to date, that you're on certain medicines that protect your kidneys from diabetes, or that you're on a cholesterol medicine that decreases your risk of heart disease. So making the diagnosis becomes important. So let's say that we're trying to figure out who has diabetes. I told you some of the risk factors, but as doctors, or if you are thinking about how to guide some of your parishioners or your friends, if their body mass index is over 25%, or if they're Asian and it's over 23%, which is small, then they should be checked for diabetes. If they have other risk factors for diabetes, like obesity or hypertension, those are polycystic ovarian syndrome, which is a hormonal condition. There are many other conditions. Then we again recommend that you are tested for diabetes. Now, if the test that's normal, what the guidelines say is that we just need to repeat it at least once every 3 years. Now, I will tell you, I try to make sure I stay on top of it every year just because people's bodies change and things can change. And you can see a quick shift in going from pre-diabetes to diabetes or normal sugars to pre-diabetes. So I try to make sure that I check my patients very regularly for this. And it's a very inexpensive, simple test that we should definitely continue. So other things that should suggest that you should be tested for diabetes. Again, if you're overweight at all, if you're inactive, if you have a family member who has diabetes, it says first degree relative, but I say any of the people in your family have diabetes, you want to make sure you're monitored. If you delivered a baby who's weighed more than 9 pounds, then you're at risk for diabetes. And again, and that's whether you had gestational diabetes or not. Just if you had a large heavyweight baby, then that is a reason to go and be tested. If you are a part of any of those ethnic groups that we talked about earlier, again, Native Americans, Pacific Islanders, Asian Americans, African Americans, higher risk. If you have high blood pressure, that's an increased risk for diabetes. If your cholesterol, that good cholesterol, the HDL, if it's less than 35, or if your triglycerides, which are the fat levels in your body, are over 250, then you should be tested. And then women who have PCOS should definitely be tested for diabetes. Other things, that darkness around your neck, if you see family members with that darkness around your neck, that's called acanthosis nigricans. And it's sometimes people bring their children in and they're like, oh, they can't keep their neck clean. And I'm like, no, that's a sign that their body is not processing blood sugar the way it should. And you'll see that in obesity. The heavier or more healthy weight they become, the less likely they are to develop diabetes. And that darkness actually lightens up. And of course, if there's any history of heart disease, then that's another reason to make sure we are testing for diabetes. All right. The main reason we want to make sure that we know if a person has prediabetes or diabetes is because of the complications that diabetes cause. If the sugar being high was just you being a little sweeter or you having a little bit more sugar in your bloodstream and it wasn't causing damage in there, then it would not matter. But the fact is, it causes damage inside your body that leads to lots of complications. I told you some of those earlier, but the number one complication that we worry about is heart disease. Why do we worry about heart disease? Well, it's the number one killer of both men and women in our country. So it's important to be able to stamp out any condition that is going to increase your risk of heart disease. When you have diabetes, though, you're at a greater risk. You are at a 2, this says 3, but 2 to 4 times higher risk of heart disease when you have diabetes. And because diabetes can go undiagnosed for many years, some people present with their diagnosis of diabetes in the hospital having a heart attack. So you don't want to be one of those people who doesn't know what's going on with their body and end up having a heart attack and then finding out you have diabetes. Whereas if we could do what we're able to decrease the risk of diabetes and to find out the diagnosis earlier, then we decrease the likelihood of you having a heart attack or stroke. The reason why this is important, because some people feel like, oh, well, people have heart attacks all the time. When you have diabetes, you have an actual 60% higher chance of dying from heart disease. So more reason for us to make sure that we treat diabetes appropriately. The higher the A1c, the more uncontrolled your sugar is, the more likely that you are to be going to have problems with heart disease and strokes. But if we can just get your A1c down by at least small increments, if we can decrease it by a small increment, for every 1% in decrease in your A1c is a 14% decrease in your risk of having a heart attack or stroke. So if you can take it from a 9 to a 7, that means that's almost a 30% decreased chance of you having cardiovascular disease or problems from diabetes. So even more reasons to make sure that you're taking your medicines, that you're living the right lifestyle, choosing the right foods, doing the right exercise to keep these numbers under control. Now, you've heard me say it many times, lifestyle changes. Well, what do I mean by that? I mean proper nutrition and exercise. A lot of times when people think about diabetes or obesity, their idea is, well, I'm going to go on a diet. When I talk about how we truly treat these conditions, it's not about a temporary fix or a diet. It's about a true lifestyle change. When you eat and you have these conditions or are at risk for these conditions, then you should be thinking about, how is this going to affect my overall health? That's how we should be eating. We should be eating in a way that is going to enhance our life, enhance our health. So choosing proper foods is going to be an important part of that. Exercise, 30 to 45 minutes, 5 days a week of alternating between aerobic exercise and resistance training will help to decrease the likelihood that you are going to develop complications or problems from diabetes. So getting to a healthy weight, eating a healthy diet, and increasing your activity is extremely important. Now, when it comes to diabetes, the main problem is carbs. So when we talk about carbs, we think about pasta, potatoes, bread, rice, grits. All of these things are carbs, but so are fruits and vegetables. So carbs aren't your enemy. It's when you focus on eating the bad carbs. As you can see, this is pizza and onion rings and nachos. And these are the types of carbs that you want to minimize. Healthier carbs are going to be things like grains and peas. Yes, whole grains are better. Now you see bread on this list and you see bananas on this list. So you are seeing that, yes, you still can have carbs, but you really want to have them in moderation. So when you sit down with your doctor, you're going to want to talk about how much carbs should you be eating. I usually tell patients to stay less than 30 to 45 grams of carb per meal if they're a woman. And for men, less than 45 to 60 carbs per meal. So we need carbs, but when you have diabetes, your body can't process it the right way. So you want to make sure that you're doing the things that it takes to really keep these sugars controlled. We also live in a country where not only are our adults increasing, those numbers where we saw an increase in prediabetes and diabetes aren't just people who are grown. These are our children as well. So it's recommended that if you have a young person who is overweight or obese or who has diabetes or prediabetes, they should actually exercise at least 60 minutes a day with aerobic exercise or resistance training. In adults, at least 150 minutes a week. That's that 3 to 4 times a week for about 45 minutes, where we do the moderate to intense aerobics, and then no more than 2 consecutive days without exercise. So I know we oftentimes go Monday through Friday and then we take the weekend off, and that's fine. But Monday, you should be right back at it. If we do these things, we're very likely to decrease our risk of having all of those complications that we discussed when it comes to having diabetes. Why? Exercise is medicine. And luckily, we live in a city where we have a great program at the YMCA called the Exercise is Medicine program. It's actually supported by some other agencies, but this is designed to promote some physical activity and optimal health to treat diseases and conditions. And studies have shown that if we do this and we do this properly, we decrease the likelihood of people who are at risk or at the cusp of developing diabetes from actually crossing over the line. So if you have any kind of interest in making sure that you don't progress to diabetes, reach out to your local YMCA here and find out about the Exercise is Medicine program. If you have a Baptist doctor, they can actually refer you directly to this program. And oftentimes they'll have some grants that may actually keep it as complimentary. This is outside of a membership. You don't have to join the gym to be a part of this. And we are really trying to get people engaged. I've had so many successes with people who have participated in this program. Some of you, however, aren't really ready to like join a group or join a program. So what can you do? First, stop and think, what is motivating your journey? What would be a good reason for you to not have diabetes, for you to not end up having pre-diabetes or any complications from a diet? What is this version of you that you're trying to be? Who is this person that you want to see live a nice, high quality life? So start with that. Then set a weight loss goal. It doesn't have to be anything that's astronomical. You don't have to aim for 100 pounds in a year. You want to aim for a good reduction of 5% to 10% over a year. Dramatically decreases your risk of diabetes or having uncontrolled diabetes, as well as other conditions like high blood pressure or high cholesterol, or having complications like strokes or heart attacks. Develop winning lifestyle habits, make a nutrition plan, determine to eat healthier. Start choosing foods that are healthier, choose fruits and vegetables and grains and beans, and stop going to restaurants and spending your money and letting them give you poorly prepared foods, even though they taste good. You want to make sure that you are choosing what's truly going in your body. Make work, home, and the grocery stores and restaurants work for you. Don't be the person who is just feeding into them. And always keep moving. Set a physical activity goal, even if it's just 10 minutes a day. Slowly work yourself up. It doesn't have to be 30 minutes at a time or 45 minutes straight. If you got 10-minute blocks 3 times a day, do this. If you're going to you can't help but go pick up some food, then make sure you're active, where you're take a 15-minute walk while they're preparing your food. Keep moving, always keep moving. And then track your progress. Take pictures, watch yourself succeed so you can congratulate yourself. If you need to have a buddy to help you along the way, develop a support group so that you'll be more motivated to keep going and to be successful at this. Because although we've talked about a lot of the bad things that can happen with diabetes, the key to this is prevention. You are in charge of this. You have the ability to keep your diabetes under control and to help decrease the likelihood of progressing to diabetes. The things you have to do, though, to keep it under control once the diagnosis has been made, we already talked about it. First and foremost, live the healthy lifestyle. Eat fruits and vegetables, take in less sugar and salt. Make sure you're physically active, at least 150 minutes a week. Take your medicines. Yes, it is crucial to make sure you do lifestyle changes. But if you get to a point where medicines are needed and necessary, there's a lot of medicines with diabetes right now that have other great benefits, where they can decrease your risk of heart disease, they can decrease your risk of developing kidney problems, and they can also help you lose weight. So talk to your doctor about finding the right medicines for you if the lifestyle changes along aren't working. But anytime you're on medicine, it is meant to help the lifestyle changes, not to be the primary focus. So take your medicines, keep your appointments, and check your sugar, because if your doctor's only seeing you once every 3 months, then you need to know what's going on with your sugar in the meantime. So make sure you check your sugar and know your ABCs. Make sure you're having a regular A1c test, that you're keeping your blood sugar less than 140/90, and that you're controlling your cholesterol, and that if you're smoking, that you quit. Make those healthy changes, and together we can stop diabetes. Thank you.
Dr. Foy, thank you so very much. That was a lot of very good information. I think that all of us on this call could use the information that you shared with us this evening, whether we're trying to help ourselves or to help people that we love and that we truly care about. We have some questions from the audience for you. Good evening, everyone. My name is Lynn Sherman. I serve as the Director of Community Engagement at Baptist Health, and I am thrilled to be here with you all this evening. So Dr. Foy, our first question, our participant says, my husband is a diabetic and loves cognac and cigars. He drinks it straight. How can I help him? We do weight training and his numbers have gone down, but he falls off the wagon and it's hard for me to get him back on track. What else can I do? He won't eat fruit, but loves vegetables.
Mhm. So that's a great question. And many people ask that and are challenged with this every day. They have people that they love who they'd like to see do better and stay on the wagon. So a couple of things that I think were said in this question. You said cognac and cigars. I will tell you the worst part of that is the cigars and not the cognac. Believe it or not, alcohol is not off limits when you have diabetes or with your general health. There's lots of studies that actually show that alcohol in moderation can help to decrease your risk of progressing to heart disease. When we look around the country at the world, actually, at some of the healthiest communities in the world, they have something that's called wine at 5. And so people who live into their hundreds in these areas that we call the blue zones, and this is something you'll be hearing a lot about coming to Jacksonville. We'll really have an initiative going to try to make our community healthy. And so having that little bit of alcohol in moderation can actually be healthy for his heart. But you want him to quit smoking, because even if he is doing one cigar, and he doesn't consider that just like a pack of cigarettes, it is. So quitting smoking is one of the biggest things that he can do. Encourage him, making sure that you are there to support him through that, helping him find ways to be incentivized to make sure that he stays on the wagon. So, for instance, you let him know, I'm going to keep this life insurance policy on high if you aren't doing what you're supposed to do. I don't want it to ever go active, but if you're not doing right, you just make sure you leave me a rich woman. That's what you tell him. But no, and I just, when I say that, but the reality is they got to find what their motivation is, the thing that is going to make him really want to have that life of health. Unfortunately, sometimes it's not until something bad happens, like a heart attack or a stroke, or the doctor tells him his kidneys aren't working well. And we don't want that. We want him to find that piece of motivation early. So unfortunately, I don't have the magic answer as to what's going to speak to him, but maybe you know him a long time, you can help him kind of figure out, baby, why would I want you to be here a long time? How do we live the rest of our golden days together as long as we can? These are the things that might help us do that. And it's going to take some work from you.
Thank you. That sounds really helpful. And I really hope that she uses some of your magic words, and love will make it happen for sure. So we have another question here. If I'm hypoglycemic and my whole family is on insulin, what can I do to keep from being diabetic? They're type 2 and not overweight. Will I be diabetic? Is it a given?
Well, I won't profess any negativity in your life. I am going to step outside of that and say that I pray that you have healing for all of your days. But what I can tell you that can happen in patients who have family history of diabetes, there's no guarantee. You have a lot of control over what you do. So even if you can't completely delay it, what you could do, completely avoid it, what you do have the potential to do if you focus on that healthy lifestyle and healthy living is that you can delay it. I told you though, some people, family history wins and it's in our genes. And so then you do all the things you can that's within your control. If you develop diabetes, it's not the end of the world. We have opportunities to really treat you in a way where it will help you live a long and healthy life. And you just want to focus on keeping it controlled if you're that person who develops diabetes. My hope is that you don't. And so keep working hard, keep coming to events like this where you can learn as much as you can and take it back to your family so that they can also enjoy the benefits of education and knowledge and putting it into action.
Thank you very much, Dr. Foy. We do have another question here. And the question is from Stephanie Gillum Brown, and she asks, can lifestyle changes reverse a diabetic diagnosis?
So that is a very good question. And a lot of people ask that, if I have diabetes, will I always have it? And so the problem with diabetes, and there have been times where I have watched things where they say, oh, well, you know how long I have diabetes. And unfortunately, that is not quite the truth. Lifestyle changes can make diabetes controlled. Like, it can push your numbers into the fives again. You can do great with lifestyle changes or medicines if you need to, but definitely you can get a lot out of lifestyle. When you get your numbers down into the range that look like normal numbers, it doesn't mean you don't have diabetes, though. And the reason I say that is because diabetes is a problem with your pancreas. So once your pancreas has been damaged, you can't really undamage it. So think of it as a piece of, like, if you burn your hand. So if I burn my hand, that skin is burned. Now there's a scar there. It still is skin, but that skin can't perform the way it normally would. So now that protection that I'm used to get from a good, healthy skin is not there. In your insides, your pancreas, once it is damaged, once it is worked hard, the areas that are damaged can't be undamaged. It's scarred. It looks like just like things that happen on the outside. And so what we want to do is decrease the likelihood that we are damaging the other parts around it, and that we are making sure that we're not making the pancreas work hard. The way we do that is to decrease the carbs. The less carbs you eat, the less insulin your pancreas has to push out, the less hard, it doesn't have to work as hard to keep your numbers in the right range. When you exercise, that makes your body release natural insulins. And so you're actually able to get more out of your pancreas. It stays in your body longer. It stays at a level longer. So when you eat, it doesn't have to push out so much. So that's why that balance of proper nutrition and exercise are so important. So don't get discouraged, though, by the notion that you can't just undo it, because keeping it controlled in a numbers that are the same as normal ranges is exceptional. When it comes to diabetes, the older we get, our pancreas naturally declines, though. The same way the outside of our body looks different and things don't, we kind of wrinkle a little bit and things drop a little bit. On the inside, things are changing too. So those organs are deteriorating a little bit. Because of that, it becomes a little bit more of a challenge to treat diabetes as you get older. So the idea is to make sure that we are not, the idea is to make sure that we are not making it work harder than it has to ahead of time. So hopefully that answers your question.
Oh, that was a very thorough answer, and we really do appreciate it. So I have another question, one more at least. In addition to Exercise as Medicine, the program at the YMCA, are there any other community resources that you are aware of? Are there educational groups? Are there support groups for people who struggle with diabetes that you can share with us?
Yes, there are lots of things in town that, with COVID, some things dismantled a little bit, but it's resurfacing. Edward Waters College had an excellent program for people with diabetes and pre-diabetes. If you're with the YMCA, they're always doing talks and programs on diabetes and diabetes prevention. The Exercise as Medicine program was actually called the Diabetes Prevention Program. There are other diabetes educators in town who take time to go out and talk all the time. Most of the time, I'm like, there are churches and things that are always having events and health fairs that are talking about diabetes, but your greatest resource is your doctor. For instance, for me, and I haven't been able to do it in the last couple of years because I changed offices, but I'm going to a new office in just a minute, and I'll be restarting what I have. It's called diabetes group visits. So instead of you coming in to see me one-on-one, you'll be there with other of my patients who have diabetes. And we talk about the challenges of taking care of your diabetes and how they are overcoming things. We'll talk about your numbers. You'll get your diabetes report card so that you will know how you're doing. And people who stick with those types of programs tend to do well. There's a plethora of internet resources, things that you can tap into where there's education and direct comments, where things are free, where it's not an expense. And so there's always opportunities, but Jacksonville is replete with diabetes education. All of the institutions have some type of diabetes education and nutrition. So just talk to your doctor about what are some of the resources that they are aware of.
Thank you so much. I had no idea there were that many resources in town when it comes to diabetes education. I love the idea of the diabetic group sessions that you're planning to do. I've read something about that in the past, and I think it would be, it's an awesome thing that you're taking the time to do, and not everybody has that available. So that's really good. And I hope that people will take advantage of that. But we want to thank you for your time today. And I do want to, and I promised that I would do this, to open up the mic. If any of you would like to ask your question out loud or yourself of Dr. Foy, please let me know and I will unmute you. Or if you'll raise your hand, we will unmute you and let you ask your question of Dr. Foy. And so I see that there is one. Mr. Emmanuel, go right ahead. Unmute yourself though, you're muted. Mr. Emmanuel, you'll need to unmute yourself. I've given you permission.
I don't know if it makes a difference, but I just wrote the question a minute or so ago, maybe 2 minutes ago. Would you rather me go ahead and state it?
Yes, please go ahead and ask your question. I don't see it in the chat, but go right ahead.
Okay. I preface my question with this history. I was diagnosed and backed by Dr. Sackett at the Baptist Primary Care when I was in my late 30s or 40. And I was in the military, and there was some question about whether I could take prescription drugs and still be worldwide qualified. So I just changed my diet and started exercising vigorously every day. And I was able to keep my A1c, sometimes 6.5, but many times 6.6 and 6.7 for many years until I got older and I was prescribed metformin, but I continued since then. And when I say got older, I mean somewhere near 60. I started to take metformin, but continued to exercise as well to this day. In spite of that, my A1c has been, according to the doctors at Mayo, that so long as I'm below 7, I'm fine, but it's still, my A1c has consistently been between 6.5 and 6.7, and occasionally 6.8. Mm-hmm. Listening to this excellent presentation, I'm wondering if A1c in that category over many years without any tests, because I haven't had a glucose oral, one of those tolerance tests since the beginning in the military. The military is the group that noticed every year my blood sugar level was going up. And that's when I got the diagnosis, but I haven't had an oral glucose tolerance test since I was in my late 30s. And so I don't know what would happen. But I wonder, am I getting damage that I'm not recognizing because my A1c is I don't know if it's ever been below 6.5.
Yes.
Mhm.
Sir. So thank you so much for that excellent question, because it gives me an opportunity to just make some clarifications for things. One, the fact that you had your glucose tolerance back then, you don't need another one. Once the diagnosis is made, it's made. If the A1C is above 6.5, and I've rechecked it, I also usually don't do an oral glucose tolerance test, because to me, that's the diagnosis is made. So you don't have to worry about that part of it. Your sugar has been pretty decent for a long time. I tend to be a little bit more of a stickler, but the thing to know is that it's not a one-stop shop. This is why having a good doctor and communicating with your doctor is important. Yes, in the general sense, there are some changes or damage that's done just because the numbers are higher than normal. And so, but minimal damage is what we're looking for in the general sense. And fortunately, because you're consistent with going to your doctors are able to monitor that, so they can check a microalbumin, which is a simple urine test to see if you're getting any early damage to your kidneys. They can do the creatinine and GFR to see if you're actually getting kidney damage. They can do EKGs and stress tests to make sure there's no damage coming to your heart. So it doesn't have to be sitting there like sneaking up on you, but the endocrinologists are the people who take care of patients with diabetes. Our goal isn't, and I'm not quite an endocrinologist, but I kind of take care of patients the way like I am. We aim a little bit lower oftentimes, but it depends on what else is going on inside your body. As a 69-year-old man who may not have any other things, if we can push your A1C down a little bit more to 6.5, then that would be good. But what we don't want is to push it to a degree where you start having low blood sugars, because low blood sugars can actually be a little bit more dangerous, and you can pass out and you can have problems. It doesn't damage your organs, but it can make you hit your head, or it happens while you're driving. So because of that, we kind of toe the line a little bit on letting it be a little bit higher. There are even some people, who, because of their medical conditions, I have to be happy with 8, or I have to be happy with 8.5. And it's because they have medical conditions that make it where if I push their sugars too low, it's more dangerous for them. So for you, it's not that your sugar has been bad. It's been decent. That'll be the word that I use. But that's just because I'm, a hard butt, and I'd like to see less than 6.5 in general, especially when you were a younger guy. I would have felt like we need to be kind of pushing that a little bit lower. And if you're really healthy now, then you can really talk to your doctor about it. There may be some other things. There are better medicines at this point, honestly, than metformin, that as a man, a Black man who is over 45, who is at risk for heart disease, if you can afford it, there are some other medicines that actually may be more beneficial to you since you're taking a medicine. And so asking them to maybe switch that out, and you may get actually a little bit better sugar control. But even if the number doesn't go down to less than 6.7, you still can get protection to your heart and to your kidneys. So you definitely want to talk to your doctor about those options. So, but congratulations on the fact that you've been so diligent about your healthcare and that you've done really well over these years. So I don't want to take that away from you and undermine the fact that your doctor was okay with 7, and that's because the American Diabetes Association told him that that was okay. I just tend to be a little bit more of a stickler.
Well, thank you very much. And I have had these creatinine and urine tests every 3 months with the A1C, and they have looked okay. When I had the Baptist test, the Baptist classes for diabetes way back there, learner. So I took 3 of those classes, and I remember listening to testimonials about low blood sugar. And when I had to go on prescription, I begged them not to give me something that was so strong, given how busy I was in my career at the time, that I did not want to have low blood sugar and have the problems associated therewith. I really appreciate that answer. Gives me a perspective. I've got physical coming up soon, and I'm going to ask some more questions. I really appreciate it.
Thank you very much. We really do appreciate your asking the question. That I'm sure that there are others who won't learn from that. So we are 5 minutes over time, but there is just one question And Jackie Nash, if you can ask your question quickly, we'll let you ask your question out loud. So go ahead and unmute yourself.
Okay, I wanted to know whether or not you could, if you've been on insulin for a while, could you change to a oral medication?
That was a good, quick question. So that is an excellent question. I take people off of insulin a lot when they're able to get their numbers down. There are some medicines right now that are available that help you lose weight. And a lot of times the weight is kind of pushing this need for insulin sometimes. And we didn't have as many of the good pills that we had available previously as well. So it really depends. Sometimes when you've had diabetes for so long, if the numbers have not been well controlled for a long time, then that damage that I was talking about earlier to the pancreas, we can't undo it. And because of that, that means your body doesn't really have the ability to make insulin. And so we would have to give you insulin. So, but that would be a good conversation to have with your doctor. Show them that you're very motivated, ask them, you know, to try some things. If you're on multiple shots, see if you can like go down to one shot and then have some other medicines that again are very good medicines, not going to put you at risk of low blood sugars, and that can work well. So talk to your doctor about it, and I wish you the best on that.
Thank you again, Dr. Foy. We really do appreciate it. Our time is far spent, and I am going to turn it over to Zavanya, who is going to close us out and give us some final announcements for what's coming up next. And I'm sure there are wonderful things. Again, thank you so much, Dr. Foy. And I'm sure the recording of this session is going to be well viewed over the next few months. Thanks again.
Thank you.
Yes, thank you so much again, Dr. Foy. It was a very informative presentation tonight. As Lynn stated, I do have some very brief closing announcements that I wanted to share with you all. So there will be an electronic takeaway handout, or actually two that will be emailed tomorrow that will cover what Dr. Foy has spoke about today. Also, I've posted a link to a very brief survey for tonight's session in the chat. So just ask that you please just take a few moments to complete that survey for us. I'm also going to include that in the email that I'll be sending out tomorrow. And next month, we will be talking about nutrition. One of the things that Dr. Foy focused on, which is very important in the topic that we discussed tonight. So we will have 3 of our community partners who are here in Northeast Florida, who are helping to improve the access to healthy foods in our neighborhoods. So please be on the lookout for that invitation in tomorrow's email as well, and all are welcome. So lastly, please take if you want to take a screenshot, just take a look at our future sessions that we have planned for the remainder of the year from September to December. I am in the process of booking speakers and confirming all of the details. So please make sure that you stay tuned for the details for those registration, for that registration information. So that ends tonight's session. Thank you so much for joining us, and we hope to see you again next month. Thanks again for joining us.